is just a quick introduction through the panel members to allow you to understand who it is that you are speaking with and asking questions of today. So I'll start and I'll then hand over to Martin. So my name is Jane Clayson. I am the recently appointed head of digital delivery at York and Scarborough hospitals. I was with the hospital last year as a contractor, but I've come back in a permanent role, and I'm really keen to make inroads into the digital delivery for the trust. And we are at the beginning of our significant electronic patient record journey at the moment. So I'll hand over to Martin at this point.
Thank you very much, Jane. So yeah, my name is Martin Dennis. I work for NHS Digital. I'm profession lead for project delivery within the organisation, and I have a couple of other titles that you can see on my description there. The CPIS bit refers to Child Protection Information Sharing Service. So yeah. Part of what I spoke around earlier today, which I'm sure you'll be able to listen to and catch up if you missed it, was around the whole aspect and difference around being a project manager in digital, and what that means, and some of the different terminology and approaches that are used in terms of things like service design, user-centered design, those sorts of aspects. So yeah, very happy to answer any questions of that ilk.
Thanks, Martin. On to you, Paul.
Afternoon. Also, I did a slot this morning talking about the frontline digitisation programme in NHS England, which I'm the programme director for. So we're supporting lots of projects like Jane's over the next 3 years, lots of NHS trusts who need to run significant digital transformation projects. My background is primarily in digital delivery in health. At least for the last 15 years or so. I'm a graduate of the Major Project Leadership Academy and a high-risk review team leader in government.
Great, Paul. Thanks ever so much. I will definitely be reaching out to you at some point. And then over to you, Lee.
Hi there. Hi everyone. My name is Lee Rogers, Digital Project Manager at Sussex Community Foundation Trust. Worked in the NHS for about 14 years now, in the last 5 in digital, leading the Trust's EPR implementation projects, and latterly doing transformation projects with our various clinical services.
Great. Thanks, Lee. And unfortunately, we're not able to bring Simon to the panel today. He's happened to be distracted by other matters. Hopefully, we'll be able to bring him to a panel in the future. So that's all the intros from the panel members, and we're going to go straight into the question session now. Have we got any that have come through already, or shall?
So we've got a couple of questions to start people off, but what I'd like people to do, because I've just discovered there's new functionality. So there is, in fact, a Q&A tab on this. So if you've got questions for anybody in the panel,
yes.
If you click on that tab and put your question in either to that, or if you're feeling brave, please do come and talk to us, because this is an informal session. I know you've been sitting and listening for a long time, but it'd be really great to make this more of an informal chat. So stick your hand up. And what I'll do is I'll come to you in order that you stick your hand up and come and have a chat with the panel and ask them their question, ask your sticky questions to them, and give them a good challenge. But also, if you've got a story to share as well, bring that along. So whilst you're thinking hard about what to ask them, I'm just going to start them off with a quick question here. So this is a question to all the panel members. I'll give you a moment to think about it, but I'll probably come to Martin first. So what is transferable project stroke delivery skills and approaches from digital that could be applied into non-digital projects?
Yeah, so go on.
No, that was it. Go on.
Okay. So there are a lot of transferable skills. A lot of what digital talks about is these aspects to what's called service design, user-centered approach to the design implementation of services. They have an iterative approach in terms of how they deliver activity in a very incremental fashion, making improvements and basically learning as they go along and doing what's called fail fast. So if it doesn't work it out quick, stop doing that, do something else. all those things are incredibly transferable to other areas in terms of how they operate. I know Joe's got a really good example of that I quote, but I won't quote hers because she's actually on the call. But there's another I had from when I did an agile training course, which has got nothing to do with digital, which is where I think it was Department for Transport, as it happened, when they were creating new legislation, rather than doing it as a big sort of slog of activity, they decided to do it in 2-week sprints and work out the change legislation and then incrementally improve that as they went along. And they found out that that was actually quicker, more efficient, got a better product and deliver what they needed. It's got nothing to do with digital, but it's got everything to do with that sort of service side. So, you know, if I think about an A&E department, it's yes, there is technology to help with the information that follows the patient, but actually a lot of it is about the environment, the physical structures, the ability for the clinicians to be able to see over desktop to see what's going on. That is all about the service design for the clinicians and people who run the service and the patients who go through that service, and think about it from this using the staff and the patients as the center of the design, and looking at how the service operates. So it's incredibly transferable skills to non-digital activities.
That's great, thank you, Martin. Lee, did you want to comment on that one? Any thoughts or ideas or suggestions from your perspective?
I think I'm probably going to say a lot of what Martin said, or probably for most of this meeting I'll say what Martin said. No, I think yes, a lot of the agile PM stuff is eminently applicable to non-digital. I guess some of what I bring is just practical experience to this kind of panel. So I've used the last couple of years, I've used a Kanban board a lot more, which is some of you probably be familiar with, just in terms of like as a very quick high level way of engaging my stakeholders, the clinical leads, the service user. They can all see what's happening, what we're working on now, any blockers, celebrate your achievements, all that kind of good stuff, which is, one of the real strengths, I think. One of the other things, maybe just think about agile methodology is the Moscow prioritization. I don't know if people will, but the must do, just that way of prioritizing, what's essential, what's a should do. We'd like to do it, but if we run out of time, we can use it as our contingency. And then maybe a could do, some of those luxury items kind of thing, which we can kind of cut. I don't know if I'm talking over people's heads here, but just that we found that as a really good way of prioritizing what our deliverables are, the essential stuff, and then going from there. So yeah, I'll leave it there.
I think that's a really good point, because with the best will in the world, we don't have the time, resources, or money to deliver everything we should do, or we could possibly do. But actually, sometimes we just need to prioritize and get out the door the things that are essential.
Absolutely, yeah. And I think your stakeholders will thank you for doing that, essential stuff. They'll thank you for delivering what they really wanted, and they won't necessarily be as fussed about the other stuff. And if it is, if it does turn out to be essential, then you can obviously make the case for further time and resource and that kind of thing. So.
Yeah, great. Jane, did you want to add anything to that one?
Just to, I suppose, extend slightly on the theme of stakeholder management. I think, particularly being new to the NHS as I am, the application of stakeholder analysis in the detail is I think a really key skill that can transfer from digital to non-digital projects, because of the nature of the cohorts of people that you are dealing with, and to make assumptions that you can address and speak to everyone or communicate with everyone in a similar way is often at the detriment to the project, because of the nature of the way that you have to sell the approach as well as the actual project itself. Because I know that there is a journey to go on, shall we say, for NHS to understand the reasons why we do things in the way we do for projects, because of often overseen as potentially an overhead or just administrative, and therefore you are almost on an uphill climb before you even start to engage with your stakeholders around the actual scope and how they can support the project.
Okay, fantastic. That's really good stuff. Thank you. Paul, I'm going to ask you a separate question, if I may, because we've got some questions starting to come through in the chat now. It's actually, so Ryan, I'd like you to come on the call and ask Paul, but also when you ask Paul, give us an idea of what you would like to see happen. Because I think this needs to be a two-way conversation about, you know, how do we work collaboratively across the country boundaries?
Yeah, thanks, Joe. So Paul got surprised by me earlier on his session when I said about how is he sharing data between Wales and England on cross-border kind of settings. But yeah, it's I guess more generic than that. It's how do we share best practice between ourselves? You know, I work in Welsh Government. I can see his colleagues from Scotland on the call as well today. How do we share across the devolved nations the best practice in digital health stuff? Because we're all aiming for the same goals of improving patient care, making staff more efficient. But how do we share the lessons to avoid the pitfalls and to maximise the benefits, really?
I think events like this are great, obviously. I mean, sharing lessons is generally about trying to bring people together who are working on similar things, who've got similar and who've got the sort of experience to share. Certainly on frontline digitisation, I'd welcome a conversation with colleagues in Wales to understand what's happening there. I have spoken to the team in Scotland and also over in Northern Ireland, and we're hoping to do a knowledge sharing visit over there actually later this year. So I'd be more than keen to make some connections with colleagues in Wales.
Quick question then, sorry, just to come back to you for a second, Ryan. Is it about the frontline digitisation specifically, or is it about you know, program projects, people working in digital and data technology projects being able to come together and share and collaborate?
Both, I guess. You know, we're trying to make the patient experience more rounded and make them a more active partner in their own care. We're trying to make the staff more efficient through giving them better digital tools and getting rid of paper wherever we can and things like that. So there is elements of that. But there's also the approaches that our health boards take in their digital teams and how they implement digital tooling and how they use user-centered design and things to make sure the users are at the heart of everything they do as they go through those processes. All that kind of stuff. How do we, you know, we're trying to drive that forwards from our side from a policy perspective, but how do we actually get that in place, I guess, is the big question for me.
Okay, I think there's something that we can maybe offer as part of that, because one of the things about the setup of the association is to have regional networks, and we've got them in England and Scotland. We haven't got Wales network yet, but we do want to set one up. But we need to make those connections and join people up. But also we have some specific interest groups around topic areas. So we've got one around change management, benefits management, but we've also got one around you know, integrated care system, PMOs. We can set them up where there is a need, and effectively what we would do is facilitate the people who are working in those kinds of projects to come together. Now we know that there's obviously a big move around the EPR program, so we can support by bringing the people who are, you know, managing the programs and projects together around those, because again there's lots of lessons to share and information to share. So but also I think there's something about being mindful that there's a crossover here between what is project and change profession and what's the DDAP profession, and maybe this is something we can bring together as a joint group, because collectively we have different tools, different ideas, different ways of working that actually it'd be really good to bring together around some of these topics. Would that be of use, Ryan?
Yeah, I think so. Yeah, one of the things we're looking to fund across NHS Wales right now is actually a piece of work to create a network across the NHS health boards and trusts of digital benefits realisation and digital change managers. Okay. So those people being embedded into those teams to actually say, this is how we're going to do it as an all Wales approach. And again, you know, there's lessons to be learned from all over the place in that kind of area. So it's how do we get that going? So yeah, there's lots there I think we can learn.
Absolutely, and we can make those connections as well, because we've got a network of benefits leads as well, and things like frameworks and resources that we can then start to connect up with your group as well. Okay, so let's move on.
Can I just add on to that very last point there? Just from my personal perspective, most recently I've found a great deal of insight and help from the EPR Futures platform, which is exactly what we've been saying there. It's a collaborative space for people on the EPR journey, and obviously it's subject specific, but it's the same principle of not having to reinvent the wheel, not having to start with a blank piece of paper, reaching out and asking for help and getting immediate responses from people who have been there before you, or can at least connect you with people that can help you with your specific requirements. And I think if that kind of approach can be widened out, then it will bring the best benefits for everyone, because nobody's doing any of this stuff really for the first time, and we shouldn't have to invest time and effort in starting from scratch.
Absolutely. And again, you know, it's a very, very big complex system. We aren't going to know all of the moving parts, but we can hopefully connect each other to them. So Lee, do you want to come in on that one?
Yeah, I was just gonna echo that, really. The blueprinting thing on that website, that is NHS Project, they do. We've done a few of those blueprints for you know, just to share that learning, where, you know, if you've done a specific project, piece of work, you can share templates, you can share lessons learned, you can share kind of that, all that good stuff with people, so that they don't have to reinvent the wheel. I think one of ours was a feature of System 1, which we implemented in our community nursing teams, called Auto Planner. So it kind of basically schedules your visits and makes it very, very efficient. So that we published that, I think, as one of our blueprints. And so that it's great to share that kind of learning.
There's a really good change management toolkit on there as well, really detailed change management toolkit.
So we have a change management group, and Julie and Jocelyn are part of the group. And again, one of the things we can do is signpost to a lot of this stuff. So if you have kind of key connections in terms of groups and networks and resources, we can include those on the HPCA website, so that we can start to direct people to where there's really good information available on a load of different topics. So do send them to us so that we can share them with everybody else. Okay, great stuff. So let me just, there's a couple more questions that have been added in. There's some comments in the chat as well. If somebody wants to have a quick look at those. Jocelyn, can you have a look at comments in the chat and see if there's anything to pull out there? Deborah has a related question, or a related comment to Ryan's question about sharing information. She says, I'd appreciate some form of workshop or session on the co-production approach to transformational change in health and social care. I think this would be a great topic, sharing best practice. So I suspect that some people will know what's going on in this space, and we can certainly connect up to the transformational change team as well, and see what's available. And what we will do is we will communicate that through the network and the newsletter, and see what we can do to connect you up on that, Deborah. Lee's got a question in there. Thinking about EPR, how do we ensure clinicians' patient time will not be encroached by patient data input focus of the EPR? What learning do we have from the exemplar programs of implementing major EPR? Anybody want to pick that one up from the panel? Who's had a go in this space?
I haven't had a go yet. We're on the journey, but what we're doing is we're certainly at early stages in building requirements for the procurement side of the journey for EPR, and we're supported by the London Procurement Partnership as part of the government offer to us. They have helped us to facilitate some high-level workshops where we bring invited clinicians in to a specific conversation around what do they envisage the EPR system and journey will look like, what do they need, what do they not need, etc. Very high level at this stage, but we're starting that journey with them from the conversations that we have. We'll then have to drill down into more detailed requirements, but then I think we need to listen to the clinicians to understand the operational pressures that allow us to avoid the potential impact of data input or data migration or data movement being the primary focus in what's already a very challenging operational environment for the NHS. We can't afford to step back from the care being given and the patient safety elements whilst we do this. So we've got to make sure we are resourced with the right approach and with a very strong plan to get through that particular amount of work.
Yeah, absolutely. Lee, I'll just come to Lee and then I'll come to you, Paul, if that's okay, because we'll get Lee's perspective and then you can talk about the strategic approach to it as well and what might be available.
No, I was just going to say we had and we have embedded in our project teams clinical what we used to call clinical assurance colleagues who would kind of go through that whole process with the users, with all the stakeholders kind of thing, to make sure that they understood exactly what they were doing, why they were doing it, and that the data thing that Lee mentioned there that was a question in everybody's mind. You know, are you watching us, or are we just doing this for management stats, that kind of things? But you can answer those queries. I think if you've got, you know, someone like me who's not frontline, not a clinician, I can say it and I can you know, demonstrate it, and my configuration, my business change guys can go through it. But if you've got actually a clinical clinician with someone with a clinical background, you know, that's that kind of story kind of telling that we heard about earlier as well, can really help allay those concerns. And I guess it is about the system as well. It's you know, choosing the right system for you. But
and again, on that, you know, lots of organisations have systems that they've gone through the pain of putting in place. So it's worth learning the lessons and you know, avoiding the pitfalls that that they've had. So we can help to perhaps connect people up if they're not already connected up through that you know, future focused network. Paul, did you want to come in around that kind of strategic approach on that?
Well, just briefly, if I may, it's a good question. And actually, the last site visit I did was up at Leicester, and you always do the walk, ran the wards, and I was asking them, and actually the clinicians there really like the product that they've got. It's product with nerve center, and actually it scores very high it scored very well in the usability survey we ran recently. But I think they like it because they were actively involved in the design of the product and the sort of workflow around it. And they were saying actually with patients it improves the dialogue, because rather than them sat writing things on paper and the patient's thinking what are they writing, they sit there with a tablet in front of them, and they can make it almost a sort of interactive. I mean, there's a cultural element within every organisation. You'll have clinicians who just don't engage with that, don't want to change. And a gem from another visit I went where I think the CCIO was saying, or the chief medical officer, I don't spend a lot of my time focusing on them. I actually focus on the people who want it to work and who want to champion it. But we know, I mentioned the EPR usability survey. So we worked with an organisation called CLASS recently to do a usability survey. And the results for the NHS were frankly appalling compared to international benchmarks. So one general theme was that we're not very good at implementing these technologies. But another very interesting one is you could have the same product, and in one organisation it would be at the top end of the usability spectrum, and another organisation it would be at the bottom. So I guess the learning from that is it's not about the product. It's about how effectively you implement that. It's about the business change. It's about getting the right sort of clinical leadership and championing around it. But yes, I guess to come back to Joe's point, lots we can share on that, and we can signpost to organisations who've done it well. And the EPR, to plug the EPR community practice again, that's that's a means to sort of get that dialogue going.
Yeah, absolutely. Lee, you want to add to the comments on that?
Sorry to come in again.
Yeah.
The very interesting survey. I don't know if it was the same survey that you mentioned, Paul, that I saw about digital capability of your users being a huge factor in their confidence and their sort of survey results in terms of usability of the system. So I think it's a really big driver, or you know, the opposite of driver, whatever that is, to people using your system well and feeling comfortable using it in front of a patient, and entering the notes in front of a patient, is their digital capability, digital literacy. And if we can help users feel more comfortable with the technology, then it really helps. So we've done some sort of evaluation of staff confidence in the system and that kind of thing afterwards, and some of the massive kind of outliers to the data. So general trend was they feel much more confident in using it, but then you get the odd person who didn't and doesn't feel confident at all. And it's generally, my experience, it was down to their digital literacy, and where we were able to kind of spend much more time with that person or people and help them, then it really helps, just confidence, and that will help that. I don't know if that is relevant to Lee's question, but
it's extremely relevant, and I think a really critical point. There's a whole load of work that's gone on around digital readiness for the system. So it's not just about the products, it's the people. Are the people ready for it? Do they have the knowledge and awareness and the skills to do it? I don't know if anybody can find the link to the digital readiness site, but that would be really good to share as well, because having the best system in the world is no good if nobody has the skills to use it. And you've got those barriers there because people are afraid of something they don't understand. So I think that's an absolute critical point, Lee. So that's a whole other area, and I think that's an area that, in terms of sharing resources, information, advice, links to training and things and what's available, is really good. So get those in the chat. There's a few questions in the chat. If anybody wants the panel to answer those questions, as opposed to just having general kind of comments and chat, if you stick them in the Q&A section, that'd be really helpful. I've got a follow-up question that's actually quite, it's following on the theme. Where's it gone? So there's a question around, there you go. Let's see where it's gone now, but there's a question around patient involvement. Oh, there it is. So sorry, can the panel please share their advice on best practices for involvement of patients within digital projects? So Paul was talking about the clinician working with the patient and sharing that information or sharing that experience. Is there something that you can recommend in terms of ways of engaging patients in digital projects? Anybody want to pick that one up? Paul, is that an area of yours, or Martin? Work with patients?
I might like a little more time to think on it. But Martin, I wonder, do you have from the CHIS work? Did you?
Yeah, so obviously the question is specifically around patients. So I'll start with the clinicians and then move on to patients. So there's a number of activities and work within NHS Digital which are affecting a variety of different clinical areas. And certainly involving the clinical people who often know the patients really well. So I'll talk about maternity, for example. So midwives will deal with hundreds, if not thousands, of pregnant women during their lifetime, whereas pregnant women obviously significantly fewer. So actually we found to a certain degree that actually the clinical people can be really helpful in terms of explain the variety of different patients and patient personas and patient experiences that need to be catered for. So I absolutely get the importance of the patients. I'll come on to it again in a second. But don't forget that the clinicians will have a really good understanding about the variety and the breadth of patients that need to be dealt with, and the breadth and challenges in terms of their ability to engage with digital. Be it my mum's severely sight impaired. I know people who've got severe disabilities. So keeping those things into account, clinicians will have a really good view on it. When talking about patients, it depends on how focused the area is and how you're trying to do it. So again, if I stick with maternity, there are actually quite a good number of charities and groups out there that will represent the patients and their experiences, and hopefully will be represented by people who've actually been through those pathways and those journeys. So they can be really helpful because they've got a voice and representation in terms of a broader set of that patient experience. In terms of using it, and that sort of approach can probably apply to a number of different areas. I get it's going to be tricky when you're talking about a particular trust trying to do, say, an A&E journey or something. Well, there's loads of different varieties there. So it can be tricky. You know, you've got governor groups who may be helpful. You know, putting out sort of requests to members in terms of members of a trust to sort of help with that, or talking to other trusts who may have engaged with a group of people who can give some expertise into that, and patient liaison groups in terms of that type of thing. So there are a variety of mechanisms you've probably got at hand. It's about how you try and navigate and use those. Certainly what we found with some areas is that once you start to build that relationship, you find that you can use those patient groups in multiple different areas, and they can be really fulfilling for both the sort of the patients, the patient groups, and the clinicians, because actually they've got a much more interesting dynamic around it. You know, accepting the patients are often giving some free time away to try and do this, because it's not necessarily always easy or possible to pay them for their time and effort. So I hope that gives some views, but happy to pass over to others.
Did anybody else want to come in on the engaging patients comment, because that's an area I think sometimes people struggle with. How they engage them.
We're not having dwelled on it. It's not something we're doing in terms of at a national level in terms of the program I'm working on currently. But that's why I was thinking back to other examples from my career. So when I worked in NHS Digital, looking after the NHS Digi Trials service. I think that was a really good example of engaging well with the public and patients, and we had a PPIE, public patient involvement and engagement panel where we had a number of members of the public who gave up their time, and we compensated it, but they were an independent panel that we were able to talk to them about the service we were developing and make sure that we had that public view on it, because it was ultimately about using patient data to support clinical trials to the benefit of patients. So having that independent PPIE panel on that particular project was really valuable. And I guess one of the key things, as I recall, on the panel, apart from the independence, was making sure you've got diversity in the panel. So that's something we strove really hard to do.
Absolutely, and not to be underestimated and to be fairly consciously planned in, because it's so easy to unintentionally bias it because of the people that are either just happen to be involved, and therefore you're not necessarily aware when you're not engaging fully in it. Just to give you an example of something, a project I was working on years ago, we looked for patient involvement and feedback into some proposed changes around physiotherapists and podiatrists prescribing and being able to access those services. And we had patient representatives on the board and the working group who brought those perspectives and also understood what the challenges were going to be. And so we did a lot of adapting for how we engaged with patients from advice from the patient reps themselves. So one of the things we did in terms of getting feedback and survey results is that we printed out the kind of the feedback forms that we wanted and the engagement forms that we wanted, and we put them in GP services, so that when patients were waiting to go and see the GP, we would get them to fill them out. We left them with an envelope, and the GP practice just sent them back in. And that gave us some real insights that if we'd have just gone with electronic, patient engagement, so, oh, here's an app, fill this in, or, go to this website, it wouldn't have been in the same context, and we might not have got the same insights. So it's not just how you engage with them, but it's where you engage with them as well, and the mindset that they're in at that point in time. So that for me was a really good lesson from my point of view in terms of getting the patient reps and people who represent the interests of the groups and the diversity of your service users involved in the approach for how to engage the wider patient and user groups. Okay, fantastic.
Can I just add to that, Jo, as well?
Absolutely.
Just a very brief point about the approach as well, because I think what we often underestimate in the NHS is the recognition by patients of, I'm going to say, the digital immaturity. They expect the NHS to be digitally capable, savvy and everything else. They would probably be very surprised when they see the brick size files that often come out. And we've just recently gone live with a clinical documentation project, which is giving handheld devices to the nursing staff to input the patient data directly without having to do written reports. And the feedback that they've got has been so positive, but almost a surprise element that we don't do this already. So when we ask for patient engagement and feedback, it's making sure that they are aware that it's not what they probably thought it would have been from the start, and therefore their feedback may have to reflect that as well. So I think that's another key point.
Yeah, absolutely. Okay, so we've got a new question. It's come in from Lee Lane. Lee, did you want to ask the panel and have a chat with them about your area of interest around the delivery of benefits? Spotted you on the chat on the call earlier.
Absolutely. I think obviously as part of my role, I look after sort of digital and non-digital programs, but particularly with digital, I think the benefits realization piece, both at the start and throughout, is a tricky domain to grapple with. So I just wondered on sort of any recommended approaches, particularly when the benefits of implementing something digital don't necessarily offer tangible sort of financial improvement in terms of that justification piece, and particularly when sort of digital programs tend to span multiple years.
It's a very good question and a very sticky challenge, I would say. Has anybody managed to make inroads into that longer term benefits evaluation piece? Martin, I'm looking at you.
Yeah, I know. I can feel the eyes on me. It's a really valid point. I mean, it's interesting as I look at how technology and digital projects grapple with the whole area of benefits, and that there's been conversations around looking at sort of outcomes and that type of thing. It is still obviously, and you're quite right, really important to identify and quantify those benefits as well as possible. Now, the whole point around digital and the agile iterative delivery is that you deliver early and incrementally. So what you should be able to do is to say, great, within a month or so, we're starting to get benefits and to move that forward. I think there's a bit of maturity to do within that, because I think some of the benefit skills need to be applied to that to that delivery of outcomes and new capabilities early on, and trying to understand what those are doing and to quantify them in some manner and follow up with that, possibly using more classic benefits management modeling to do that, rather than just saying, well, we delivered a widget and it's being used 100,000 times a week, so it's doing something, but to actually quantify what that thing is and therefore build on it. So it should, and I don't think, to be honest, I don't think we've cracked it even within my organisation, but it should be possible to use those sorts of mechanisms and say, right, well, it's now being used. Let's use the NHS app and COVID Pass. We know it was used millions of times. Well, each time equates to a benefit of use for somebody in real life, and it's trying to make sure that you've got those proxies and tracking. It does mean you need to design the digital thing to count the numbers, so that you've got that quantification. It can be tricky to work out, has it been beneficial, and I think we hesitate within the health sector to say, was this information useful for you, yes or no, or are you happy with the service, and your various smiley or unhappy faces. But maybe some of that's what's needed to help with, trying to encourage either feedback or to demonstrate that people are using it, and that type of thing. I think the challenge for digital is if you get it wrong, people don't use it, and it's really difficult to recover people who are turned off by a poorly delivered service early on. So that there's a bit of a sort of bit you need to be careful about it. But it's what I talked about this morning was around the fact that you've got to use both project and digital skills at the same time, and I think we need to bring them together rather than trying to polarize them and say it's a digital thing, only use digital skills, because actually you need both sets.
That's great, thank you. I've got Blanca who's put her hand up in the chat, so might relieve some of you that. So Blanca is part of my team at Health Education England, and she's a benefits manager. So Blanca,
I will just add something. I was working in the IT department in Leeds Teaching Hospital, implementing EPR in the hospital. So I will add that, and linking to your conversation before, Paul, benefits management not only will help to track and know that we are doing a good job, it will help to implement it to the clinicians and explain them why that new technology will benefit them. Implementing new technology to clinicians that they are really busy, and it's something that they think that is on top of their job, and sometimes it's really hard to embed new technology in their role. Benefits management will help them to understand why they need to use new technology. In my previous role, the most of my time was not helping them to know how to use new technology. Is to helping understand them how that technology will help them and will make them more efficient and productive, and spend that time, not only be more literate in terms of technology, that spend that time in patient care and be able to use that time with them. So just to add that benefit, if we are able to implement benefit in any digital project, it will help not only us as a developing the new technology, but the clinician to understand why. And when we were implementing technology in there, it helped the patient as well, because looking at a clinician with devices on their hands doing things that they don't understand, instead of doing medication or prescribing care, that was weird for them. But if the clinician understand what they were using, why they were using it, and how it will benefit them, the patient feel more safe and secure in the hospital, and it will be very beneficial to implement benefit wherever we go. Hope that helps.
That's really good. I think this is a really interesting area, and there's an opportunity to do an awful lot of improvement. But one of the things that we say about benefits is benefits only exist if there's somebody who values that change. And I think one of the things that we're not very good at yet is thinking about the benefit from the recipient's point of view. And that's about, what does that benefit look like to the clinician? What makes it a benefit for them? What makes it a benefit for the patient? We often talk about numbers and money, but that's from a strategic perspective. That's not from the end user's perspective. Yeah. So part of it's about how we frame those benefits, and then how we measure whether we've achieved those.
How we share them as well with the clinician. In the bringing clinician to the digital department, that massively helps as well, because they can tell us, or we can learn from them what is the benefit of that new technology that we are trying to implement. So I support the IT and all of the clinicians that want to come and do benefits as well.
Absolutely. We have a framework around that, and a community. So get connected in, Lee. Paul, did you want to come in on that one?
But just to stress the importance of getting your change and benefits management right in these projects. I mentioned earlier the usability survey. Just writing a business case, having a stab at some numbers, and then implementing some tech and thinking the job's done. It's not. You'll end up with poorly implemented tech that's not delivering the benefits. The hard work, actually, if you think about putting in an EPR, and I'm sure the same's true of other digital services, you implement, you've then got a recovery phase, to be honest. We use the term stabilization because it's a bit more friendly, but actually you'll probably see some disbenefit and a dip in performance. And then you've got what we term the optimization phase, and that's where you really work to drive those benefits out. And clearly from the sort of results we're seeing globally, we're not very good at that optimization phase. So when you're sort of putting these projects together, don't just think about the 2 years to implement the thing, think about the 2 years afterwards, where you're actually going to optimize how it's used to drive out benefit for your staff and patients.
Yeah, absolutely. And we know this is a tricky problem, and it comes back, one of the things that for me, this is an area that we need to work on, but it's not something we can work on in isolation in our profession. This requires multidisciplinary working. So one of the things I've been talking to the finance profession about, the Healthcare Financial Management Association, is what can we do to collaborate on bringing together our skills and our knowledge around this. HFMA has its Institute for Value. They obviously have a lot of financial skills and data analytics skills and modeling skills. You know, there's all the stuff around investment decision making. You know, we're the ones that have to write the business case, but actually we need them to work with us on it. So for me, there's a whole cycle of collaboration that needs to happen around the investment decision making process, the business case development, the working with the change management team around the stakeholders, the engagement, who are the benefits for, how do we make sure that they are what the benefits that the end users are actually needing. And then around how we do evaluation to evidence that. So Lee, you'd be delighted, I think, to hear that the next event we're planning in November is with HFMA on all of this, and seeing what we can do collectively when we bring our respective skill sets together and work on something that provides a more joined up approach to all of this within the profession and for our organisations and our particular programmes. So it's a really good question, and one that is an area that's a real gap, and one that we've got a huge opportunity to collaborate with others on solving. So
great. As an accountant, I'll be sure to attend that one in November.
Absolutely. You can help us design it if you like, because if you've got this as a challenge, then you're seeing there's a problem that needs fixing, and I suspect you've probably got some ideas about what you'd like to see in place. Now he's gone quiet.
Yeah. We're running over time, Joe. Oh, sorry.
Sorry, I'm just saying that I'll help Lee if you want to help. Don't you worry, you are not alone.
Yeah, we'll get a planning group together and to see that we can get a really well designed event that's really engaging for people, that creates some really positive outcomes. Okay, so there's been some really great questions and some really great insights from people, some really great comments in the chat. Thank you everybody for getting involved and contributing to that. That's been really helpful. If we didn't get to your question, I'm sorry about that. But again, you know, answer each other's questions in the chat. Make sure you connect with each other as well. Ian, you asked a couple of questions. Hopefully you've had some answers that direct you to the information that's available to deal with the questions that you asked. And if not, we can always follow up with you and direct you to where the resources are to answer your questions. So very quickly, just to wrap up the session, I'm just going to share my slides very quickly with you. And thank the panel. So panel, thank you very much for your time, your insights, your shared stories, your ideas and suggestions, and also for discussing with the group around some of these very sticky problems. It's been a really fantastic day, and this has been a really great session at the end of what's been a great day. I somehow lost my connection there to the laptop. Let me just change the micro power outage there. That was exciting. Can you all still hear me?
Yes.
Good. Would have been a bit of a damp squib ending otherwise. So thank you very much, Jane, for coordinating the group at the start and the session, and for your insights. Thank you, Martin, for a fantastic session earlier and for your comments and thoughts. Lee, thank you very much for contributing your ideas and suggestions as well, and participating. And Paul, again, thank you for your session earlier and for contributing much more to the session at the end today. Absolutely fantastic. So just reflecting back on what was a really great day. We've had some really great insights. We talked about the developments that are happening in the profession. We launched the association. Martin's excellent session looking at you know, what's different around digital and what's not, because actually there's a lot of commonality in there as well. We had a really insightful and heart kind of warming and wrenching session from Joe Jolly, talking about the environment and what we can do and how we can mobilize around that, and the digital and the data analytics that can help support the cause and whatever cause that we're contributing to. Paul, around the frontline digitisation, really good insights into that programme. Really good storytelling from Bryn. You know, there's definitely some things I'll be taking away from him in terms of telling those short personal stories to make things really hit home. And some good insights around, you know, the complex programme PMO, and that's sparked some real interesting questions and debate as well. So a real mix of insights from the digital and data environment, and I think there's some really good and useful understanding around digital and data, but also some very common understanding about actually these are fairly consistent challenges, and actually if we work together we can share knowledge and skills and tools and ways of working that can help everybody to deliver more effectively and collaboratively in a multidisciplinary way, because we need all of those perspectives and voices to make it work in practice. So lastly, we have our next event on the 29th of November, and I said hopefully we will be doing that with HFMA on investment decision making, business case evaluation and benefits. So get that in your calendar now, and we will send the invite out shortly. And if you haven't already done it, if you do sign up to HPCA, you know, you can continue to be part of the community. We're transitioning over from NHS Project Futures, so we need you to sign up. We will be sending out notifications, so anybody that hasn't done it, we'll give you sort of other opportunities. Brilliant opportunity to promote the fact that we are now moving into this next phase for the profession as a whole, and what a great journey it's been so far, but this is really just the start of the next steps. And just to say, Sam, thank you so much for being involved and engaged, contributing, chatting, asking great questions, commenting, and just being a brilliant community. Thank you so much, and it's been an absolute pleasure. Thank you to the team for running it, for all the volunteers who's run the sessions. Another brilliant effort in what is, you know, more than usual, actually challenging times because of the so many different things going on that distracting our attention. So thank you for making it happen. It's been awesome. And thank you again for being a great community to be a part of. And see you next time.
Thank you.
Thanks.